Welcome to the deep dive. Today we're navigating the intricate world of otosclerosis. It's a fascinating bony dysplasia of the otic capsule, and it can present with deceptively subtle imaging findings.
That's right.
Our mission, really, for you, our fellow neuroradiologists, is to demystify the critical radiological aspects. We want to dive deep into its classification and, importantly, the key HRCT and MRI findings.
Indeed. And otosclerosis, it's progressive, typically hitting young and middle-aged adults.
Yeah.
You get this aberrant spongy bone replacing the normal, dense and chondral bone.
And hearing loss is the main symptom people notice.
Predominantly, yes. But the disease itself is quite dynamic. It goes through phases: vascularity, decalcification, then recalcification. So radiology becomes absolutely pivotal.
Even in subtle early stages.
Especially then, or for things like precochlear implant assessment. We need to understand what's going on structurally.
Okay, so let's start unpacking this. Our sources really emphasize that otosclerosis isn't just one static thing, it's more of a continuum.
That's a key concept. We generally categorize it into fenestral and retrofenestral forms. Although, purely isolated retrofenestral disease, that's pretty uncommon.
So fenestral is the main one we see.
It's the more prevalent type, yeah.
Yeah.
It mainly hits the lateral wall of the bony labyrinth, typically starts right there in the fistula antifenestrum.
Mm-hmm.
That spot just anterior to the oval window.
And that leads to the classic stapes fixation and conductive hearing loss.
Precisely. Then you have retrofenestral or cochlear otosclerosis. That involves the cochlear capsule itself, maybe the vestibule, semicircular canals.
Resulting in sensorineural or mixed hearing loss?
Right, either from direct injury to the inner ear structures, or maybe proteolytic enzyme release affecting the cochlear fluids. Understanding this continuum is really crucial for interpreting those complex audiograms we sometimes see.
Because a patient might start with conductive loss.
And then develop a sensorineural component as the disease progresses into the cochlea. It really guides how we think about follow-up and patient counseling.
Okay, so given that continuum, what are we actually looking for on high-resolution CT? That's our workhorse for temporal bone, right?
Absolutely. HRCT is the gold standard. The spatial resolution is just perfect for these tiny, intricate, bony structures.
So for fenestral disease?
You're looking for small, hypodense plaques, demineralized areas, often starting right at that fistula antifenestrum. Sometimes they're tiny, like 1 millimeter.
Wow, okay.
And as it progresses, you might see more extensive involvement around the oval window, the round window margins. Sometimes, though rarely, maybe 2% of cases, you get complete oval window obliteration.
And for the retrofenestral tech, what's the classic HRCT look?
That's the pericochlear hypodense double ring. It used to be called the fourth ring of Valvasori. It basically shows that the demineralized spongy bone within the cochlear capsule itself.
A ring around the cochlea.
Kind of, yeah. The double ring appearance.
Yeah.
And it's often bilateral, quite symmetrical usually.
Now, this brings us to something really useful in practice, the CT grading systems. Tell us about Simons and Fanning. How does that help us in reporting?
Oh, it's incredibly useful. It gives us a structured way to categorize how much the cochlea is involved, moving beyond just describing it.
So how does it break down?
Grade 1 is simple, solely fenestral disease, no cochlear involvement. Grade 2 means you've got patchy, localized cochlear disease, and we subdivide that 2A for basal turn, 2B middle, 2C apical turn involvement.
Okay.
Then grade 3 is the most extensive, diffuse, confluent involvement of the cochlear capsule.
And the real power here isn't just consistency.
Exactly. It's not just about better inter-observer agreement, though that's good too. It actually turns HRCT into more of a prognostic tool. We know that higher grades tend to correlate with earlier onset of SNHL and increasing severity.
Which is invaluable for talking to patients and planning management, like deciding about cochlear implants.
Absolutely.
And thinking about surgery, like stapedectomy. HRCT gives us more than just finding the plex, doesn't it? There's a whole pre-op checklist.
Precisely. Beyond just identifying and grading the disease, HRCT is indispensable for checking things like the oval and round window status. Are they obliterated? We need to assess the facial nerve canal, critically its relationship to the oval window. Is it dehiscent? Overhanging?
Things the surgeon absolutely needs to know.
Definitely. And the jugular bulb, too. Is it high riding, potentially in the surgical field?
Yeah.
All this granular detail helps tailor the surgical approach and hopefully reduce complications.
And it also means we need to keep mimics in mind, right? Like cochlear clefts.
Or tympanosclerosis, yeah. You need that strong clinical correlation to make sure you're calling it correctly.
Makes perfect sense. So shifting gears slightly, how does MRI fit into this? We use it less often maybe, but it has a role, especially for active disease.
It absolutely complements HRCT. MRI is invaluable when you're trying to assess active vascularized lesions, particularly if the hearing loss is sensorineural or mixed.
So what are the key MRI features we're looking for?
You might see intermediate signal on T1 weighted images in the affected areas. But the really key finding is mild to moderate enhancement after gadolinium contrast.
Where specifically?
In those paralabyrinthine and paracochlear regions again, off of the fistula antifenestrum, around the cochlea where you might see the HRCT changes.
And these can be subtle.
Oh, definitely. Very subtle. You could easily overlook them if otosclerosis isn't really on your radar initially, which means you need optimized protocols.
Like what?
High-resolution sequences, definitely. Things like dedicated CISS or Fiesta sequences are great for the fluid spaces. And really focus T1 pre- and post-contrast imaging, paying close attention to those specific locations. That's essential to pick up these nuanced changes.
Okay, so bringing this all together then. For a patient where we suspect otosclerosis, what's the bottom line approach?
It really has to be a synergistic approach. You need to integrate the clinical picture, the audiogram, the symptoms with targeted imaging, both HRCT and sometimes MRI.
HRCT is the cornerstone for bone and surgery planning.
Exactly. It maps out the structural changes. But MRI gives you that extra layer, especially for detecting disease activity and evaluating the sensorineural components when things aren't straightforward.
So this deep dive really underscores that understanding the whole spectrum of otosclerosis, that continuum we talked about, and leveraging both modalities smartly. That's really key for accurate diagnosis and guiding management for these patients.
Couldn't agree more.
We hope this helps you, in your practice, feel more confident identifying and characterizing